Kumar Dubey, since Professor H.K. Tiwari is not keeping well and therefore he has absented from the course, we miss him. And joining me are Dr. Barun Nayak, Dr. Lalit Verma, Chairperson of Scientific Committee of All India Ophthalmic Society, and Dr. Dinesh Talwar is expected any time. At the outset, I thank the Chairman Scientific Committee for two reasons. One, for allowing this course, and other for joining us as faculty, because his joining us as faculty makes this course the consensus and voice of AIOS. In these times of E-era, when everything is available on click of a mouse on internet, what is the idea of holding these courses? In reality, we are passing through dangerous times. Maybe 20 years from now, in order to publish a book or to circulate an information, you were required to have credibility as a scientific worker and a long track record as an academician. Also, the publisher had credentials for publishing a particular work. But now, with the facility of internet, anything which is authentic, unauthentic can be pasted in one or the other form on internet, and this can lead to tremendous misinformation and confusion to the basic learner. It is for this reason that we are en face with this experienced faculty. We have deliberately chosen two people from posterior segment side and one person from anterior segment side so that we can have a mix of views. I attend courses on endophthalmitis and they go on describing preoperative precautions, OT size, type, they quote large studies. They also discuss rare microaneurysms and unusual patterns of endophthalmitis. I must candidly say this is not the objective of this instruction course. This course is going to be a practical course and it is largely confined to acute bacterial postoperative endophthalmitis, which is the commonest complication. Based on information on ENET, unfortunately a nexus has built up between phaco surgeon and VR surgeon. Because VR surgeon space that I operated 17 cases of infective endophthalmitis and vision was 6/6, which can never be a reality. And therefore, whenever a phaco surgeon encounters a post-operative infection, his first reaction is to look up to the vitrio surgeon, can he be helped? This is not actually a healthy and scientific situation. Most often, the phaco surgeon continues denying the possibility of infection for 2-3 days unless the condition worsens to something like this. If phaco surgeon learns to accept the responsibility at the very first suspicion of post-operative infection, he will not require help of vitreoretinal surgeon, and that is going to be the mainstay of this course. All of us are exposed to surgical treatment in our third year MBBS first time. And if you remember those days of education, your consultant surgery, when he takes a round and if the houseman reports that this patient had fever, he either changes the antibiotic or adds another antibiotic. Second stage of infection is pus in the wound. Third stage is peritonitis and fourth is septicemia. I am giving a very simple correlation that I compare fever with little heightened reaction in the anterior chamber, pus in the wound with hypopyon, peritonitis with involvement of the vitreous, and septicemia when there is panophthalmitis. If you are able to treat post-operative infection at this stage, maximum at this stage, you actually get results. But if you ignore infection beyond these two stages, what you do is actually a struggle and a mix of academics with a struggle. Regularly, I notice that two studies are quoted in all courses of post-operative endophthalmitis. One is endophthalmitis vitrectomy study, which is actually a dated study now because it belonged to times when sutures were given in cataract surgery, and this study never addressed management of post-operative infection. It only addressed the role of vitrectomy in late presentations of infected eyes and role of systemic antibiotics. Second study is ESCRS multicentric study, which is also regularly projected in these courses. This is also not having any relevance to post-operative infection because it only assesses the role of intracameral antibiotics, and interestingly, the infections still occurred after use of intracameral antibiotics. This course is targeted to a basic anterior segment surgeon practicing in a small town. Dinesh, welcome. I welcome Dr. Dinesh Talwar, who is equipped with operating microscope, phaco machine, A-scan, biometry, slit lamp, and an ophthalmoscope. He does not have a B-scan. He does not have immediate access to a vitreous surgeon. He doesn't even have a pathology lab within his access for a rapid culture in sensitivity. The idea is to enable him to diagnose infection in his cases with facilities with him to manage the same successfully and to avoid vitrectomy in majority of the cases. As I said before, infection is neither a surgical pathology nor it is a posterior segment pathology, and therefore role of vitreous surgeon should be only occasional. The studies that describe about postoperative endophthalmitis invariably mention initial symptoms are blurred vision and a red painful eye with chemosis and lid edema. Unfortunately, this still persists in the print. Can I ask to open the discussion Dr. Nayak that how much does he agree that this is the presenting symptom of postoperative infection? Dr. Nayak, please.
Yes, thank you, Dr. Arvind. Good morning, everyone. Whatever the features which were described earlier, for suspicion of postoperative endophthalmitis or infection, probably doesn't hold true now because of the sutureless cataract surgery, where routinely there is not much reaction and not any congestion, there is hardly any edema, lid edema or pain. So in that scenario, because earlier when surgery per se, the cataract surgery per se was a little more traumatizing, therefore these reactions were more, and with this super added infection or that both combined together, really that was the feature which was earlier main presenting features. But now probably the main presenting feature these days, the sutureless cataract surgery, is the diminution of vision. And in particular, if first day patient says, I can see well, and if the vision has gone down afterwards, then one has to be really very cautious. And some patient, if rings me back, the doctor, I was seeing when you saw first day, I was seeing well, today I am seeing less, then I don't even say that start any treatment or enhance, say immediately come and we want to see you. So that is the probably
now. The message is that we should not look for a painful red eye with chemosis and lid edema. There can be infection in as quiet an eye as I have shown here in this picture. My second question is to Dr. Lalit. Instead of patient reporting certain symptoms, do you think it is critical responsibility of the operating surgeon to evaluate the signs on microscope?
You see, like Dr. Nayak rightly said, in today's era, we don't depend on symptoms too much. You see, pain does not occur in all the patients, as classically book teaching is there that if you have pain, suspect endophthalmitis. So pain even historically occurs in only 25% of patients have endophthalmitis. So today, all surgeons should be familiar with their own, slit lamp signs every day. Classically, we tend to see all patients on day 1, 3, and 7 every time. So you are familiar. So therefore, every patient should submit slit lamp examination and depend more on signs than symptoms.
Dinesh, to elaborate on this, will you wait for this picture 1 with a hypopyon, or it should be possible to diagnose postoperative infection in a picture like this, which is really my own postoperative infection? What are your indicators for suspecting postoperative infection?
I think as you pointed out, it's important to pick it up early. So now, what you have in the first picture was actually a classic. There's no confusion about it. But as Lalit mentioned, if you have been following up your patient regularly, then in the picture below, you would be able to pick up an increase in the number of cells in the AC. You would be able to pick up early changes in the vitreous, and that would occur before anything more happens. So it's possible to suspect infection at
short of hypopyon,
this stage, provided you have been seeing your patient from day 1.
Okay. Hypopyon occurs when the number of cells is more than 50 cells per high power field in the aqueous humor. An infection is considered to be present when 5 or more cells are present in per high power field. I would invite comment from Dr. Nayak on first day hypopyon. We have been saying that hypopyon is a sign of a full-fledged infective pathology, but sometimes you get a hypopyon on first day. Should you call it infective invariably, or it could be inflammatory? I'll invite comments from Dr. Nayak.
When the first day, probably to suspect infection is very, very rare, because unless the load, bacterial load is very high and it's a very invasive organism, then it's a different matter altogether. But most of the time, probably the first day is, if hypopenia you are seeing, it may not be, it just may be the excessive reaction. In that case, of course, you have to, but still, the suspicion will be there. So you have to be very careful, and you have to, whatever treatment you are giving, you have to follow it up very, very meticulously.
Okay.
So I would
What
like to
he-
modify this a little
Please.
bit. I think in any case when you have a hypopion, and if you have a hypopion on the first day also, you must suspect endophthalmitis. The only thing is, if your normal reaction is that you have a little hypopion, that is a different situation.
Okay. I take both the points together. First day, if there is a massive hypopion, which is generally because of actual inoculation of Pseudomonas in the eyeball cavity. A minimal hypopion on first day, as we have shown, coupled with a good view of the retina, which was immediately viewed, generally indicates that it is an inflammatory pathology. This is my own case.
So in this patient, when the retina view is very good,
Yeah.
minimal hypopion should point toward excessive reaction.
Yeah. So I intensified topical steroids, and this is the picture at 6 hours. The hypopion appears to be disappearing, and the retinal view has also improved. And this is picture at 36 hours. Hypopion has completely disappeared, and a good red glow is obtained. The message to take home is that a minimal hypopion on first day, with good view of the retina, with reasonable good visual acuity, does not call for a very alarming action. You just intensify the topical medication, but as Dinesh said, you must follow these cases actually on hourly basis, because that suspicion of infection should never be ruled out till things have settled. Now, all the discussion that has gone so far drives us to a proper standard slit lamp drill in any case where we suspect postoperative infection. And the proper standard slit lamp drill is to actually darken the room, to increase the magnification to 16x, to make a narrow point of the beam, and to examine the anterior chamber. Now this shows reflection of slit beam on the cornea and on the iris, and the intervening anterior chamber is optically empty. This is a normal situation. With modern cataract surgery, minimal finding that you can get is some floating pigments or maybe some very small cortical flakes in the beam of light. But if you can actually trace the beam of light from cornea up to the surface of iris, this is known as grade 1 flare, and this is always inflammatory. If the light beam is still more hazy and partly obscuring the pattern of iris, and the suspended particles are more, you are still safe, you can consider it inflammatory. And if it is dense enough to obscure the pattern of iris, but there are appearing some suspended particles, morphology that is outline of which can be defined under slit lamp, this indicates that there is a strong likelihood of infection. To summarize, once you see cells in the anterior chamber, and the easiest way to identify whether these are cells or suspended particulate matter, that you should be able to define the morphology of the structure which is suspended in the beam of light in the anterior chamber, and suspicion of infection should become very strong once you have cells in the anterior chamber. I'll request Dinesh to serially tell us which postoperative days he calls his patients and what does he look for.
Basically, day one is the most critical. You must call all patients. I call all the patients on day one. Day one should actually have, the most important component is a slit lamp examination. If there is any doubt that there's a reaction, then you must dilate and look for the vitreous also. That's the second
good.
important thing.
That's good.
Vision is not the most important thing on
Yeah.
the day one, though you should take it so that you can have a serial follow-up. A patient who's 612 today, 69 tomorrow, even if he has a little bit of cells, I will be reasonably comfortable.
And you
But
will
a patient
invariably
who's-
like to examine posterior
Yeah, but a
segment.
612 going to 618 is a very major thing for me.
Lalit, how do you think it is important to look at posterior segment, and is it your routine to look at posterior segment in all cases?
Yes, sir. It is a routine that all patients, I must do slit lamp examination and distant direct followed by indirect. All patients, irrespective of anterior segment, posterior segment surgery. This is a mandate. Slit lamp, distant direct and indirect.
So in modern days, when the external signs are not very prominent, it is important to evaluate both the anterior segment and the posterior segment thoroughly before settling with any issue of infection.
Yeah, Arvind, can I just add something?
Please.
No, I wanted to add because he is a retinal surgeon. That's why, because the cases which come, he doesn't see routine cases, post-op cases of cataract. Therefore, probably his recommendations are every time you have to see the slit lamp. Of course, there is no doubt about it, and especially and also the fundus. But in routine cataract post-operative patients, because I personally really don't see each and every patient on first visit or second visit fundus, unless there is some doubt. Then definitely
See, the
I
midway
see
is,
thoroughly.
Dr. Nayak, midway is if you are not accustomed to seeing fundus, though this kind of lethargy should be done away with, you can always make the slit beam coaxial.
Yeah.
After you have examined
Glow,
the
glow,
anterior
you can see
segment,
glow.
you make the slit beam coaxial and you should be able to appreciate uninterrupted red glow. If there is any interruption in the view of red glow, then a detailed fundus examination should be conducted. Dinesh, there is a system of grading the haze in vitreous, because now we are approaching from identifying features in anterior segment to posterior segment. And this system also gives a guideline to the treatment. Like they have these 4 pictures I have shown. This is grade 1 vitreous haze, wherein there is minimal haziness in the vitreous. This is grade 2, wherein vessels can be seen up to second order. This is grade 3, wherein only the first order vessels can be seen. This is grade 4, wherein some red glow can be seen, and this is grade 5, wherein everything is yellow, nothing can be seen. Do you consider, Dinesh, haziness of vitreous as a guide to your treatment modality, that you like to give antibiotics or you like to operate?
So I think that's a beautiful illustration. Just looking at this, you can actually say this is the way to manage endophthalmitis. The fact is that if you're at grade 0 or grade 1, that means you have a very clear view, you don't have any clumps of vitreous haze, you know that you don't have a vitreous infection going on right now. What you have is an anterior
You
segment
address
reaction.
the audience, Dinesh.
Yes. Now, when you come to the second picture, is it possible to remove the superimposition wala photograph?
Yeah, sure.
Yeah. Now, if you see, you can see that there are clumps in this. This is not just a little haze. There are clumps here. This is very clear evidence of an early infection. And actually, endophthalmitis requires, as a diagnostic, that there is infection going into the vitreous. So this is the first sign, and this means patient has to have an intravitreal. There's no two ways about it. There's only one caveat. That caveat is a patient who pre-existingly had a vitreous haze for some other reason. Maybe you operated a diabetic who had some vitreous haze because of an old hemorrhage. That's a different situation. A clean patient, the type which is normally operated by most cataract surgeons, should not have any kind of haze.
Okay.
Anything beyond that is actually the one on the third slide, the one on the left, definitely needs an intravitreal. Fourth is actually an indication for a vitrectomy. Though if you don't have a facility for a vitrectomy, you should still give the intravitreal and immediately refer this patient. Because don't let a delay occur in the management by the vitreoretinal surgeon. He also needs time to prepare.
All right.
So that is and of course, fifth, there is no doubt.
So I take that up to stage 1 and 2, you will only give intravitreal injections
Yes.
of antibiotics. Stage 3, you may consider intravitreal injection, and stage 4 will be your
100%.
go sign for vitrectomy. In other words, we have to have early surgical intervention, if at all, not intervention at this stage, because this will
Here
not
there is no
produce-
doubt. I mean, everyone does it. So there is no-
Right. Now, I have observed that phaco surgeons don't actually